Hello class! Did you know that our body consists of over 600 muscles that allow us to make movement and control many organs? But have you ever wondered what will happen if there is a lack of protein dystrophin in the muscle? It will be muscular dystrophy. Muscular dystrophy? What is it? Okay, let me tell you what is muscular dystrophy. Muscular dystrophy is a group of more than 30 genetic diseases that cause progressive degeneration of muscle fibers, which result in weakness and loss of muscle mass in voluntary muscles, which will lead to increasing level of disability. It also begins by affecting a specific group of muscles before affecting the muscles more widely. Muscular dystrophy are caused by genetic mutation which due to dysfunction or lack of protein dystrophin that are essential to generate and protect muscle fibers. Each disorder varies in severity, age of onset, pattern of inheritance, and affected muscle groups and other organs. There is no cure for muscular dystrophy, but medication and rehabilitation program can manage symptoms, slow the progression, and prevent complications. Do you know what are the causes of muscular dystrophy? Muscular dystrophy are due to mutation on the X chromosome which interfere with the production of muscles. It is genetically inherited, which means one or both parents may pass a faulty gene to their child, even if the parent doesn't have the condition. Muscular dystrophy causes include: there are 9 types of muscular dystrophy, which are the prevalence of muscular dystrophy are found to be 19.8 and 25.1 per 100,000 cases across 19 countries in years. Muscular dystrophy can occur at any age, but most diagnoses occur in childhood. Based on the previous study, the researcher found that males are more likely to develop symptoms than females. And according to Tiadom et al., myotonic, Dutton, and facioscapulohumeral muscular dystrophy were found to be the most common type of disorder. A study in Malaysia found 43 newborns are affected by muscular dystrophy each year. Okay, you all must be curious how a person with muscular dystrophy looks like, right? So now we will look at on the clinical features of muscular dystrophy. In muscular dystrophy, there are 7 clinical features such as muscle wasting, joint stiffness, excessive daytime sleepiness, facial weakness, shortness of breath, muscle aches, fall, collapse, and sudden death. These clinical features may cause problems in several aspects such as poor balance, poor functional mobility, waddling gait, cough deformation, reduced dexterity, coercion, swallowing difficulties, speech and language disturbance.
Next, let's look at muscular dystrophy according to ICF. According to ICF, there are impairments, activity limitation, participation restriction, environmental factors, and personal factor. For impairment, patients with MD usually have muscle weakness, reduced ROM, loss of muscle strength, and poor balance. For activity limitation, they will have poor functional mobility, difficulty in eating and belting, and also speech and language disturbance. For participation restriction, they have difficult to participate in education and also they have restricted in community life. For environmental factor, they will have supportive family, home and pedicare accessible for wheelchair. And lastly, for personal factor, they may be male, 7 years old and Malay. So let's look at the model of intervention, which is PEO model. This model assumes that person, environment, and occupation play 3 major components which interact to each other continually across time and space. So this is a few explanation on how PEO model is related with MD. Let's proceed to frame of reference, which are biomechanical FOR, rehabilitation FOR, and educational FOR. First one is biomechanical FOR. It is known as remedial approach. It's focused on increasing strength, range of motion, endurance, and coordination. The second one is rehabilitation FOR. It is compensation when remediation of underlying deficit is not possible. And lastly, for educational FOR, it is used to educate patient family members about his condition and help them involve actively in patient's daily activity and daily care. Now, let's look at what intervention is suitable for muscular dystrophy. The first intervention is musculoskeletal management, which is stretching. The aim of this intervention is to maintain range of motion of joint. It is also to prevent and minimize contractures and deformity. For approach, biomechanical FOR and remedial approach is used. There are a few types of stretching. Firstly, active stretching, active assisted stretching, third, passive stretching, and lastly, prolonged elongation using positioning. For frequency, it should be done a minimum of 4 to 6 days per week. Stretching should be done at home or school as well as in the clinic. These are examples of active self-stretching. Firstly, gastrocnemius stretch. Second, hamstring stretch. Third, soleus stretch. And lastly, wrist and finger extension stretch. Then, for passive self-stretching, there are two examples, which are gastrocnemius stretch and hamstring stretch. Firstly, for gastrocnemius stretch, the patient must stand at a wall. While standing at a wall, position one foot in front of each other. Then, lean forward, keeping the back knee straight and toes pointed forward. Lastly, hold for 60 seconds, relax, then repeat it again. The second one is hamstring stretch. The patient must lay at the corner of two walls, place a heel on the wall and the other leg along the wall on the floor. Second, it should slowly move closer to the wall until a stretch is felt in the back of the thigh. Lastly, hold for 60 seconds and repeat 1 to 2 times again. Lastly, for wrist and finger extension stretch, it is self-stretch. For instruction, firstly, place palms together in front of face, slowly lower hand, keeping elbows out until a stretch is filled. Then, hold for 60 seconds, rest, reposition and repeat 60 seconds again. So let's look at the intervention for mobility such as passive standing device, wheelchair prescription, and orthosis. Firstly is passive standing device. It is used to prevent overexertion and falls in patients with MD. The next one is wheelchair prescription. It is used to maximize performance in occupation through adaptation of the environment. Firstly, late ambulatory stage. It is an ultra-lightweight manual wheelchair with solid seat and back, seating to support spinal symmetry and neutral lower extremity alignment, and also to swing away footrest. The second one is early non-ambulatory stage, which is a manual wheelchair with custom seating and recline features, might serve as a necessary backup and a power wheelchair. The next one, as you can see, a powered wheelchair is also suggested as a functional community ambulation. These are the evidence base of passive standing device. Lastly is orthosis. It is used to prevent and minimize contracture or deformity. For the type, AFO, KAFO, long leg braces or calipers are used. For the step, the orthosis should be custom molded, fabricated for comfort and optimal foot-ankle alignment. So these are the evidence base of orthosis.
So now we will go to the fourth intervention, which are adaptive devices for self-care. The aim of this intervention is to enable client to be maximally independent to perform functional activities with the help of assistive devices. And the approach used for this intervention is rehabilitation FOR. These are some examples of adaptive devices. Okay, then we will go to the last intervention, which are postural correction. The aim is to reduce pain by protecting skin, muscle and joints from developing pressure sores. The approach used for this intervention is educational FR. For the precautions, the family members should be aware of the duration of positioning and make sure the client is comfortable in that position. For resting on the back, first support the head with pillow and then put a foam pad under the heels so that they do not touch the bed surface. Next, position the arms at side and keep the feet from leaning on the bed's footboard. For resting on the side, first support the head with pillow. Place a pillow behind the back for support. Place a pillow lengthwise between the legs. Place a foam pad between the ankles and between the bed and the ankle. Keep the feet from leaning on the footboard and support the top arm with a pillow. Before sitting on the wheelchair, place a cushion on the seat. Place the foam pads under the calves and feet. Then, place the neck pillow on the neck to support the hip. Support the both arm with a pillow and let the both arm rest on top of the pillow.
For the conclusion, muscular dystrophy is a very rare disease and comprises a large and heterogeneous group of genetic disorder. It is a very serious disease in which muscle weakness gradually increase over years. It also has problem in ADL, IADL, sleep, leisure and social functioning. However, the cure is not present until now, and effective management and treatment can give some release to patient.